Hello. We're going to talk about anesthesia for plastic surgery, liposuction, and non-operating room anesthesia, or better known as NORA. So let's talk about a couple of non-operating room anesthesia overlying kind of principles, and then a couple of specific locations, and then we're going to say the radiology for a different lecture. So these are often, these are GI suites where you're going to be doing colonoscopies, ERCPs, and upper GI endoscopies, or the electrophysiology suite, working with the cardiologist, either for cardiac catheterizations, pacemakers, and ICD insertions or ablations, fertility labs, and office-based practices. Typically, it's important that you make sure that the people assisting you, the non-anesthesia personnel, are familiar with what is taking place. They typically should be at least one other ACLS trained personnel available, particularly the people who are monitoring the patients in the recovery room should be ACLS trained. The attention to detail around medication safety, being able to access medications that you need, having the equipment that you need, and choosing the right patient, the right procedures are very, very important, because there tends to be much fewer regulations and awareness of the implications of anesthesia in these NORA locations as opposed to in operating rooms or even freestanding surgery centers. So some overarching principles is general anesthesia and MAC are the most common, but regional anesthesia is an option and becoming more common for some particular situations when, of course, the procedure is amenable to that. Monitoring must be consistent with ASA standards. So ASA standards apply whether the patient's in the operating room or outside the operating room whenever an anesthesia provider is providing anesthesia. So you must monitor pulse oximetry, ECG. If you're going to be providing general anesthesia or moderate to deep sedation, you must monitor end-tidal CO2. You must monitor blood pressure. You do not have to monitor temperature, but they highly recommend monitoring your temperature, and you must have the ability to monitor temperature when it would be important to monitor temperature. There's typically limited PACU capabilities. As I mentioned, there should be at least one person in the PACU who is ACLS trained, but because there's limited capabilities, typically it's felt that the patient should be have a rapid return to baseline functioning, be street ready very quickly after undergoing an anesthetic. Specific challenges because of some of these locations in the cath lab, in the GI suite, in radiology, you have limited access to the airway, limited access to the patient themselves, and very limited resources, be that the equipment, even you may not have an anesthesia machine, or personnel. If you do not have, a scavenging system, if you don't have piped in gases, then TIVA and MAC may be the only options that you have. Is it safe? So much like MAC, anesthesia in the non-operating room settings may have higher risk than in an operating room. For one thing, a lot of the patients are undergoing MAC, and as we mentioned before, MAC can carry as great or greater risk even than general anesthesia. But out of operating room locations specifically have, in at least one study, resulted in 7 times more frequent claims for inadequate oxygenation than in the operating room. Often the problem is, again, severe respiratory depression, oversedation, and failure to rescue, particularly failure to recognize these events because you're in a dark room. Radiation X-ray equipment may be in your way. The gastroenterologist has a scope in the patient's mouth. You're down on the other end. It's hard to see things. Sometimes you cannot use oxygen. And so the sort of hazards may be significantly greater. And many times these patients are very ill patients. In fact, they're too sick for the operating room sometimes. So that's why they're down in radiology or the GI suite or the cardiac cath lab having something done. In at least one study, they showed that the greatest risk occurred in office-based settings. 10 times higher risk or 12-fold higher risk in office-based setting as compared to a day surgery center. Intermediate to that is a hospital-based surgery center. And NORA risk, even though there aren't good data, appear to be somewhere in the middle lower than office-based, but higher than day surgery. So again, it's really important that you realize that you may be the person who's responsible for the equipment, that things you take for granted, showing up in a hospital, an operating room, a surgery center, and knowing that there'll be a fiber optic scope there, there'll be a defibrillator, there'll be piped in oxygen, may not actually occur in these remote locations or in offices. You may not always have the emergency medications unless you bring them. In fact, it's felt that the reason Joan Rivers died was because the surgery center the gastroenterology center did not stock succinylcholine for emergency airway management. They did not stock it because they did not want to have to stock dantrolene, because dantrolene is expensive. And if you use succinylcholine, it's recommended that you have dantrolene available. And so when she apparently developed laryngospasm, they did not have succinylcholine available to use to break that laryngospasm. Likewise, you may not have the 20% lipid emulsions to treat local anesthetic toxicity. There may be only one pulse oximeter, which is in the procedure room, and it's shared with the PACU. Or in the PACU, there may be only one pulse oximeter because they typically just expect one patient to be there. But if you have two of them, then they'd have to be sharing it. And the person giving the sedation may have various credentials and experience. So if you happen to be in an area and you're the only anesthesiologist and there's many other procedure rooms, when something happens, they may look to you to come in to intervene or to rescue. So you need to be certain that you're clear on what role you play there. So a question, a 22-year-old had a hernia repair with minimal sedation, 2 milligrams of midazolam and 40 milligrams of propofol for the injection of the local anesthesia. Which of the following are required by the ASA before this patient can be discharged from this office-based procedure? A, the patient must be able to urinate. B, the patient has a blood pressure within 40% of baseline. C, the patient has an escort home. D, the patient has tolerated blood PO intake. E, the patient is alert and oriented. Which of those is required before their patient is deemed ready to go home? The only one that's absolutely necessary is the patient have an escort home. All the rest of those are highly desirable and recommended, and depending on the particular situation. But the patient, according to ASA guidelines, must be discharged to in the presence of a responsible adult to take them home. Some of those other things may not be important in specific situations, and we'll try to cover those in the talk. So there's basically three phases of recovery. Phase one is the situation where the patient is typically recovering from general anesthesia. And generally it's felt that the recovery room needs to be similar to an OR recovery room, where you have trained personnel and all the equipment that you would have in an operating room recovery room. But if you're not providing general anesthetics, then you may not need a phase one recovery area. Phase two recovery is a recovery area with limited resources. And this is a recovery area where typically it felt that the patient has met recovery when discharged to home. So they may need to wait around for someone to pick them up. They may still be a little bit sleepy, but they do not need all the resources that they would in a regular recovery room. And phase three recovery is that actually occurs at home when the patient returns back to their normal baseline state. So there's various discharge scoring systems that one can use, and studies have shown that it's unclear whether it's the actual meeting the requirements of the discharge summary, or just simply that because someone is using this discharge summary and having to tick off different criteria as like on a checklist, or having the patient be assigned a number, that it just results in enhanced monitoring of those patients and avoidance of premature discharge. So in an outcome-based system, you want to make sure that your parameters are met, that you have a patient who's to some degree oriented or back to baseline, if that patient was oriented times 3 to begin with. Stable vital signs. It doesn't have to be back to baseline, but there shouldn't be any need for intervention. There shouldn't be widely erratic vital signs. That the patient's pain, nausea, and vomiting are controlled. Notice it doesn't say that the patient doesn't have any pain or nausea or vomiting, just that it be controlled. No unexpected bleeding. Being able to ambulate if the patient is required to ambulate or was ambulating on admission, and return to some kind of baseline functioning. The ASA, again, does require that a patient be discharged to a responsible adult. It's not okay to put a patient in a taxi and have the taxi driver bring that patient home. You do not have to make sure that the adult actually takes the patient home. You don't have to follow them out to their car, but they should be there in the recovery room picking the patient up. The patient should be able to tolerate orals if the need to tolerate orals and staying home is a requirement. So if the patient is adequately hydrated, then they should not need to drink before leaving the PACU. And in fact, forcing liquids on individuals who are not ready to drink, particularly children, have been shown to increase their nausea and vomiting. So unless you are depending on the patient having to maintain orals immediately after discharge, then they don't need to demonstrate that in your recovery room. Same thing with voiding. Patients undergoing minimal low-risk procedures, cataract surgery, there's no reason to have that patient required to void before being discharged. Even increasingly after spinal anesthesia, hernia repairs, gynecologic procedures, things that we routinely would always have patients wait around until they're voided. Many people are saying that if you have mechanisms where the patient knows how to come back, if they can't void, or you can ultrasound that patient's bladder and assure that they don't have excess volume in their bladder before leaving, that there's no reason to have that patient wait around to void. But we do know that patients who receive opioids, those who receive spinal anesthesia, those who have surgery close to the genital urinary tract are at increased risk for having, and patients who are older and patients who are male have increased risk of having urinary retention. So if you are going to target a population that you may desire that voids beforehand, those would be the ones you would target. Let's talk a little bit about the electrophysiology suite. Typically, you may be doing cardioversion or ablation procedures, or as we mentioned, insertion of devices. Cardioversion is usually a very short, quick procedure. It requires a deep depth of anesthesia, either deep sedation or, in fact, momentarily general anesthesia to have the patient not remember they're being shocked. So typically, if the patient has a reasonably favorable airway, you can just pre-oxygenate the patient with nasal cannula or a face mask, give them a bolus dose of propofol with full monitors on board, and then when the patient becomes unconscious or deeply sedated, they do the cardioversion and the patient wakes up. Ablation procedures are much more lengthy. They require often mapping, full drapes, sterile procedure, and generally these patients will need general anesthesia. Or they will need to have very favorable airways where they can tolerate lengthy procedure under deep sedation, or a very, very cooperative patient who's wide awake, and you're just there to monitor the patient. But what typically doesn't work well is a patient who's sort of lightly to moderately sedated, who starts to become disinhibited. Usually the patients are supine. Usually the cardiologists are going through from the groin, so you do have access to the airway, but there's usually fluoroscopy in the room and a lot of other equipment. And again, typically you are working with providers who know nothing about anesthesia or airways. And often these patients are very sick because they can have cardiomyopathies and lethal arrhythmias such as ventricular tachycardia, but sometimes there can be just older individuals who have atrial fibrillation, or they can be very, very young, healthy individuals who have an SVT. So devices are the other reason why you may be asked. Most pacemakers are put in by cardiologists alone with just some minimal sedation, but some of the cardiac implantable electronic devices you will be involved with because these patients usually have some sort of significant underlying heart disease. In fact, I always say healthy hearts don't get ICDs. Pacemakers are a form of an implantable cardiac device, and implantable cardiac defibrillators is the other form, and some of these devices contain both. Again, an indication for an ICD is a very, very low EF or lethal arrhythmias. The patients will, if they're undergoing an ICD placement, will often require inducing multiple shocks to make sure that the rhythm can, or induction of arrhythmias, so these can be very uncomfortable for the patient, and so they are much more likely to require more significant sedation or general anesthesia than simply a placement of a pacemaker or simply a change of a battery in either device, which can usually be done with just sedation. The endoscopy suite is also a common place where you're going to increasingly provide anesthesia. In fact, I think currently more anesthesia is done in NORA than in operating rooms, and most of it is done in gastroenterology suites. So let's start with a question. A 44-year-old obese female with common bile duct stone for a laparoscopic cholecystectomy. Which drug may worsen her symptoms and outcome of her procedure? A, omeprazole, B, midazolam, C, metoclopramide, D, fentanyl, or E, lidocaine. This will also be true of a patient who's having an ERCP done for removal of that common bile duct stone. Which drug may worsen her symptoms? Yes, fentanyl. Remember, opioids can cause spasm of the sphincter of Oddi. The sphincter of Oddi is the sphincter that is right where the common bile duct feeds into the duodenum. So patients who have cholelithiasis or common bile duct stone may have worsening of symptoms when given opioids. So there's lots of non-surgical interventions for pancreatic or biliary disease, which are usually done through endoscopic retrograde cholangiopancreatography, or ERCP. We are much more likely to be providing anesthesia services for ERCPs than we are for just simple colonoscopies or endoscopies, because they generally require a deeper level of anesthesia. Often these patients are elderly and ill, and as you can see, the patients in this kind of position, they're in what's called a sloppy prone or almost prone position, so there's limited access to the airway. So if you've got an obese patient, a patient with sleep apnea, they can be very challenging to provide anesthesia to. Most ERCPs can be done with MAC or a moderate to deep sedation, but some of them will require general anesthesia, particularly in those patients who are more ill, who have more challenging airways. Percutaneous gastrostomies or feeding tubes can be done either in the GI suite or in interventional radiology. Most of the time, these procedures are done without anesthesiologist giving sedation. They're given minimal to mild sedation by either the proceduralist, the radiologist, gastroenterologist, or a nurse working with them. But you may be asked to take care of the sicker, more challenging patients. The GI procedures tend to be a little more stimulating because they actually use an endoscope to go down, so it's less like an upper endoscopy. They distend the stomach, they find an area, and they put a needle percutaneous through the outside. Now, they do give local, so the thing that's most stimulating generally is the placement of the endoscope past the oral pharynx, and then when they actually pull the feeding tube out through the stomach. IR does it slightly differently. They place a very, very small nasogastric tube usually through the patient's nose. They use that to inflate the stomach. They then use a wire technique where they then also pull the feeding tube through the stomach and out through the abdominal wall. Again, generally, the first thing you should always think of when you're asked to come to the GI suite or radiology suite to do something sedation for a simple procedure like this or a simple endoscopy or colonoscopy is, why do you need me? Why has the patient either failed, or do you think the patient's a poor candidate for your giving the patient anesthesia, or meaning the radiologist or proceduralist giving it? Which symptom is not commonly associated with GERD? A, cough, B, chest pain, C, abdominal pain, D, hoarseness, or E, laryngitis? Of all of those symptoms, which one is not usually associated with gastroesophageal reflux disease? Yes, abdominal pain. Abdominal situations that cause abdominal pain can then secondarily result in GERD. But generally, patients who simply have GERD will not have abdominal pain, but all those other symptoms they will. So what is GERD? GERD is the retrograde movement of gastric contents through the lower esophageal sphincter into the esophagus. Aspiration is different than GERD. Aspiration is when the movement of that gastric contents actually get past the upper esophageal sphincter and past the pharynx and into the lungs themselves. Heartburn is the most common symptom of GERD. About 20% of the population, though, has heartburn once a week. About up to 10% of them have it daily. Other symptoms of GERD include chest pain, dysphagia, pharyngitis, cough, asthma, hoarseness, laryngitis, and even sinusitis. Risk factors for reflux or GERD is an incompetent lower esophageal sphincter, or anytime the lower esophageal sphincter pressure is less than the intra-abdominal or intragastric pressure. Because remember, things flow along pressure gradients, so if the pressure in the stomach is higher than that in the esophagus, then it's likely to push contents from the stomach up into the esophagus. Patients who have esophageal dysmotility and hiatal hernias also have risk factors for having GERD. GERD is not generally caused by symptoms of GERD may not be completely correlate with the amount of reflux the patient has, is what I'm trying to say. So patients can have reflux and be completely asymptomatic. Now, GERD is associated typically with the following conditions: pregnancy, particularly late third trimester pregnancy, particularly active labor, significantly obese patients, obstructive sleep apnea, patients with gastric outlet obstructions, patients with gastric neuropathy, such as gastroparesis that occurs in diabetics, particularly type 1 diabetics, and anything that increases the intra-abdominal pressure. So the risk of aspiration with GERD, or with risk factors for GERD, is not well established. I know everybody asks patients about GERD, and everybody often has in their mind the correlation of GERD and aspiration going together. But actually, if you look at the literature, there is not a high association of simply a patient reporting having GERD and the risk of aspiration. But if you are concerned about a patient with GERD, there's a couple of key components. What you want to do is decrease the amount of volume that the patient has to aspirate, or the amount of volume that's in the stomach, and you want to increase the pH or decrease the acidity of that material. Because it's not so important whether the patient aspirates or not, it's what they aspirate. So aspirating particulate matter, such as undigested food, is much worse than aspirating liquids. Aspirating bile is worse than aspirating gastric contents. Aspirating highly acidic fluid is worse than less acidic fluid. And the more volume that one aspirates, the worse that is. So by using prokinetics such as metoclopramide, you can empty the stomach, reduce the contents. There's less fluid to regurgitate and aspirate. Be aware that there can be extrapyramidal effects and chorioathetosis when using metoclopramide. It can also prolong your QT and result in arrhythmias, particularly if given as a rapid IV bolus or given in more than a 10 milligram dose. So metoclopramide does nothing to change the pH of the fluid. All it does is decrease the amount of fluid in the stomach. So you want to decrease the pH, then you use H2 receptor blockers or proton pump inhibitors. H2 receptor blockers do not change volume. All they do is change gastric acidity. And they will not change gastric acidity of fluid that's already in one's stomach. They will only change the gastric acidity of fluid that now is being produced and moving into the stomach. They also may decrease actually lower esophageal sphincter pressure. So there's actually a slightly increased risk of aspirating with H2 blockers. It's just that you're going to be aspirating less acidic fluid. But if you use it in conjunction with a metoclopramide or a prokinetic, then it should overall decrease your risk of reflux and aspiration, because the H2 blockers will decrease the acidity and the prokinetic will decrease the volume. Remember, H2 receptor blockers can cause confusion and agitation and even psychosis, particularly in elderly patients, particularly if given repeatedly, generally not in a single dose as being used in the preoperative period. Now, proton pump inhibitors do two things. They also decrease the acidity of the fluid, and they decrease the amount of fluid being produced. Again, they have no effect on fluid that is already in the stomach. They will just decrease production. So the decision to perform a rapid sequence induction must clearly balance the risk of aspiration and airway management. And this is actually quite controversial because it's often felt that patients are put at risk by having a rapid sequence induction performed when the risk of aspiration is actually relatively low, or that the risk of aspiration could be lowered appropriately and adequately with prokinetics, H2 blockers, PPI drugs, versus doing a rapid sequence induction. If you've got a patient who has a challenging airway, if you've got a patient who has a cardiovascular dysfunction, a very, very ill patient, a rapid sequence induction may put them at harm. So it's really important that one always uses medications to lower the risk of acidity and the volume, even if you're using a rapid sequence induction, because a rapid sequence induction does not completely guarantee that you will not have aspiration of fluid. And remember, it's more common to aspirate on emergence of anesthesia than it is on induction of anesthesia. That's the second most common time to aspirate, is on induction of anesthesia. So doing a rapid sequence induction is only going to affect the risk of aspiration on induction. It's not going to affect your risk of aspiration on emergence. And that's why these medications are particularly important. The other way to affect pH is through sodium bicarbonate or Bicitra, which will neutralize the acid that's already in the stomach. So along with metoclopramide, it's the only way to affect fluid that's already been produced in the stomach. Particulate antacids worsen aspiration pneumonitis and should not be used, so you don't want to use things like Mylanta or Maalox. You want to use Bicitra or sodium bicarbonate. Cricoid pressure is used to obstruct the potential flow of gastric contents into the pharynx and trachea. It does nothing to change the acidity, obviously, or the amount of volume that is in the stomach. Cricoid pressure actually has been shown to decrease the lower esophageal sphincter tone, much like H2 blockers do. So it actually may increase the risk of having fluid move from the stomach into the esophagus. It's just that it is designed to prevent the fluid from moving from the esophagus into the oropharynx and then down into one's lungs. But remember, cricoid pressure may actually worsen visualization of the airway. It may cause laryngeal obstruction. It may cause laryngeal trauma. You have to use a lot of cricoid pressure to actually block off the esophagus, which can result in displacement of an unstable cervical spine. And if the patient does retch or regurgitate, it can result in actually esophageal rupture. As I mentioned, it may worsen reflux by lowering the lower esophageal sphincter. Complications of cricoid are more common in the elderly, children, pregnant patients, those with cervical spine injuries, and anybody who has difficulty palpating the cricoid cartilage because the patient themselves is difficult due to airway deformity, prior neck surgery, obesity, or because you have an unskilled person who doesn't really understand much about how to do cricoid pressure, actually doing the cricoid pressure. Thank you very much for your time.